Thank you, Dr. Ragapathy, and thank you for the invitation of the organisers to come here today. I'm afraid that I'm going to talk about the long-term effects of childhood radiation and chemotherapy for cancer in childhood, and the only novel thing that I can think of about this is that you are seeing far more of the patients now than ever before, and furthermore, the patients are living to grow up. So that over the past 30 years, we are now getting to the point that 80 to 90% of children who have had cancer will grow up and will come to see you with all their many problems. Curing childhood cancer, however, doesn't come without cost, and over 25 years after diagnosis, there will be a massive penalty to pay. Some people will have a second tumour, 6 times the population rate. Very specific tumours will have extra health problems and more issues like bone cancer or thyroid cancer or hypothyroidism. And 30% have a risk for aggressive breast cancer over many years. From the children's cancer cohort in the United States, looking at 20,000 survivors over 30 years, 18% of that cohort have died of the consequences of their past treatment. And for medulloblastoma, only 65% are still alive 20 years later. The long-term outcomes amongst adult survivors is grim. When you compare it in the top left here to the United States population, that horizontal line at the top, there is an all-cause mortality increase, along with a cumulative increase in incidence of CNS neoplasm, and particularly of all-cause morbidity and mortality, you can see is very different from the rest of the population. The survivors continue to have risks that go on for the whole of their lives. So you'll be seeing more and more of these children as they grow up. A more recent study published in the Journal of Clinical Endocrinology in 2016 points out that the risk is higher for higher risk therapies. There's more hyperthyroidism, thyroid nodules and cancer, more obesity, diabetes mellitus, and growth hormone deficiency. Both men and women are at risk for gonadal failure, and the most important thing is that a proper follow-up takes place so that there is prompt management of endocrine-related morbidity to improve quality of life. If you look at the quality of life in cancer survivors, it's not as good as the rest of the population. And you can see on the right there in green that patients who have been subjected to cranial radiation have a particularly bad quality of life compared to their peers. They graduate from high school less, they're less likely to do tertiary education, they marry less and have more unemployment. And 40% of them will have chronic health problems. And in particular, in the context of what we're talking about, they have memory processing deficits, and that makes a huge difference to their daily function. They don't comply with their medication, they have depression, they have eating disorders, and their self-esteem is often very poor indeed. Neurocognitive function is horrible, and you can see why when you look at that very alarming picture. This is the picture of the vasculature inside the brain of a young person who has had cranial radiation. You can imagine that this does not improve your mental function, nor does it improve your compliance with medication, or remembering to go to the doctor, or remembering to take your medications. Stroke risk is also markedly increased. At a median age 31 years, 28 survivors of this big cohort of over 1,300 survivors had had a first stroke. The dose of radiation that they had received was an independent predictor of the risk of stroke, and 1 in 8 survivors after cranial spinal radiation will have a symptomatic stroke by the age of 45 years. So that's a pretty grim outcome. From an endocrine point of view, we know that cranial irradiation damages the hypothalamic pituitary axis, particularly the hypothalamus, which is more radiosensitive. The higher the dose, the more the damage. First you get reduced cell division, then you get progressive atrophy of the hypothalamus and pituitary, and eventually you get a delayed onset of endocrinopathy. For many years, we've known about the order of deficiencies of growth factors and other hormones from the hypothalamic pituitary axis that was defined years ago by Steve Shallett. Growth hormone is almost always the first one to disappear, followed by gonadotrophins and variably by the other hormones. More recently, a study from 2011 confirmed that from the Marchant group at St Jude. The longer the duration after the radiation, the more the risk of a problem. Both cranial radiation, craniospinal radiation, total body irradiation, and even chemotherapy alone have been shown to have hypothalamic pituitary deficits. And on the right there, you can see a much more recent publication from Wartner et al. In 2018, which says exactly the same thing in a much larger cohort. The problem is that as one is developing all of these problems, they all occur together. So along with evolving growth hormone deficiency, making the child grow more slowly, there's early puberty, making the child grow faster. So you don't actually see these abnormalities unless you look very carefully and you look at the growth chart. If the child has had spinal radiation, the spine won't grow, and so they'll end up short anyway, making it all the more important that you make a proper diagnosis and you fix what is able to be fixed. That is, deal with the growth hormone deficiency. So there are many indications for growth hormone treatment in children. There's a whole long list of them here. What do we do about our adults? Who do we see that might be candidates for growth hormone treatment? Well, the people that we see are those who have ongoing growth hormone deficiency, those that have had cranial irradiation, craniospinal irradiation, and total body irradiation. So we're back to the cancer survivors. We know that girls largely stop growing by the time they're about 14 years, boys a little older, and that's the time where, if they are lucky enough to have had growth hormone, it gets stopped. But it's also the time that they're going through the senior years of schooling. They need to have their concentration skills and their intellect functioning at the very best. So what are the clinical features of ongoing growth hormone deficiency in an untreated deficient adolescent? Tiredness, lethargy, poor concentration, awful school marks, can't participate in sport, get depressed, start gaining weight with a metabolic distribution, and they're very hard to diagnose and very hard to treat. So doing a normal IGF-1 and saying, oh no, there's nothing wrong with you now, is not at all helpful. After puberty, an IGF-1 does not tell you whether a patient is growth hormone deficient. So if you want to make this diagnosis and manage the patients properly, you have to either repeat their growth hormone testing, or if they have panhypopituitarism, you can assume that they will have ongoing growth hormone deficiency. So just to give you an example, this is a 10-year-old girl who had headache and vomiting, had a huge tumour that you can see there, was diagnosed with a medulloblastoma and was treated with craniospinal radiation chemotherapy. She had ongoing posterior fossa syndrome. She was very unstable on her feet. She managed to get growth hormone treatment, so she grew a little bit better, but because of the spinal radiation, she ended up shorter than her family. But after the age of 16, she had to stop growth hormone. The government wouldn't provide it anymore, and her family had to provide the growth hormone for her, and it made a massive difference. It allowed her to concentrate and finish her schooling. She was much more mobile. She, instead of walking in such a fashion that she needed a second person to hold on to her, she was able to independently ambulate, and she can now go to university. So I think there are subtle but very important advantages to treating these patients. We've just taken a retrospective audit of all of our survivors of allergenic bone marrow transplant that has been done in our institution over 30 years. And just to tell you that short stature in our cohort was very similar. Many of the patients were much shorter compared to their families and to their family potential. So in a big cohort, a very similar outcome. We know that growth hormone treatment is associated with concerns about its safety, and I think in the interests of time, I'll just point to these things that you know very well, that over many years people have now been looking at various studies of growth hormone treatment in patients who have survived cancer, and there is no known association to date that is clear for a link between growth hormone and recurrent or new cancer. Meningiomas occur with monotonous regularity in patients who've been exposed to cranial radiation, as you can see on the right there, increasing with time. But the occurrence of meningiomas and gliomas were not associated with growth hormone in a big study of 12,000 cancer survivors in the United States. The SAGE study from 2018 was finally reported and showed some slight oddities that do need following up. If you exclude high-risk leukemias, there was definitely an increase in bone cancer reported in some cohorts, but the numbers are extremely small and it's very unclear what this means long-term. Bladder cancer and CNS tumours were also reported as being mildly increased, but there was no information beyond childhood, and there was very heterogeneous data available and no information of very long term for the adults. So keep an eye on this, but we don't know whether there will be problems. And again, we think that there's robust evidence for children, less so for adults, and there may be risks, but the data's not clear at the moment. Probably growth hormone is fairly safe. ACTH deficiency is relatively uncommon compared to growth hormone deficiency after this sort of problem, but in large studies there's somewhere between 4 and 12% risk with the passage of time. The problem, though, is that ACTH deficiency is very hard to define. It's subtle, it's dangerous. If you have to have a general anaesthetic and you don't wake up afterwards, or you suddenly have gastroenteritis and become hypoglycemic and go into a state of shock because it's unrecognised, this is very, very serious. So you need to follow these young people with at least annual morning cortisol levels. And if the cortisol is starting to go down, the patient probably needs to at least have steroid cover for stress and proper instruction. And then as it goes down further, they may need long-term steroid replacement. There are, of course, many other endocrinopathies and other different things that we will see, and I know that skin cancer is not an endocrinopathy, but when you think that nearly 12% of patients surviving cancer eventually have skin cancers, often in the field of radiation, and you're probably the only person who's going to end up seeing them, it's very important to remember to look. There are very many other bowel cancer, breast cancer, bladder cancer that we'll go through. So will hormone replacement cause breast cancer? That's the first thing that parents say when we have to give hormone replacement to the children. In the old days, half of the radiation that was given to the spine went straight out the front of the chest, and these young women had enormous risks for breast cancer when they were older. Nowadays, the spinal radiation is changed slightly so that it's conformal to further back in the chest, which is probably going to hit the heart instead. But the relative risk is definitely higher. And all I want you to take away from this is the fact that there was a surveillance practice study done about 4 or 5 years ago for women who'd had exposure to radiation for their lymphoma treatment, and 25% of those women in a high-risk group and age group had never even had a screening test. So it's very important when you're dealing with children and adolescents who've had radiation exposure that you make absolutely certain that they go to adult care with adequate surveillance information. There's a recent breast cancer study which similarly suggests that there is a small increase in breast cancer risk in leukemia survivors who have been exposed to low-dose radiation. Thyroid cancer, we all know, increases after radiation exposure. It's about 20 times the population risk, and the risk does not go away with time. It continues 40, 50 years after the radiation exposure. The lesions are usually papillary cancer, they're usually multifocal, they're often metastatic, and from our data, we have shown a number of patients who have had lesions under 5 millimetre in diameter, single lesions, which have been taken out for one reason or another, which have been clearly metastatic, not only into local tissue, but into the vasculature, and in one case into muscle. So I think these are aggressive lesions that need very good care. And the picture that I've shown several times, some of you may have seen before, of this young man tells you why the patients who've had cranial radiation get thyroid cancer. He asked me why he couldn't grow a beard in the centre of his chin, because it was the exit beam from his cranial radiation. So if we look at, again, this is our studies of the patients who'd had radiation for TBI prior to bone marrow transplant. Once again, we saw roughly the same number, about 1 in 3 chance of malignancy within a thyroid nodule, and many, many thyroid nodules in 36% of our cohort. So that's a very significant risk and must be followed. Weight gain is increasingly noted as these children grow up and survive long term. The picture is of a little girl who was a lovely, thin, fine 4-year-old child. She's now enormously overweight, constantly food seeking, completely out of control in terms of satiety. In a study of 75 survivors of ALL, looked at 10 years later, many of the girls, and particularly the boys, were obese, with a significantly elevated Z-score for their fat mass, and sarcopenic obesity was very obvious in all of these subjects. Diabetes is more common. In a 2,500 5-year survivors, the median follow-up of 20 years, the cumulative incidence of diabetes was 8%, and it's much higher if they've had abdominal radiation, particularly to the pancreatic tail. So you need to follow the patients from that point of view. If you look at 10,000 survivors from another study reported from 2010, there is, again, a very large overall diabetes mellitus risk, particularly in the leukemia and lymphoma group. And I'm sure you'll all see patients like this. In our study, we saw a very similar long-term outcome. Overweight, obesity, hyperlipidemia, hypertension, impaired glucose tolerance, and diabetes were all more common in those that had TBI, particularly the darker blue squares, and those that had cranial radiation in between the non-irradiated ones. So across the board, the risks are higher. We know that bladder is very sensitive to chemotherapy. That's why you have high washouts when you're using cyclophosphamide therapy to try and reduce that risk. We know that abdominal radiation, pelvic radiation, gives exposure to the bladder, and that can be exacerbated by smoking and alcohol as well. COG guidelines from the United States are still very uncertain and unclear about what we should do about this. And I think it's very easy to, it's very easy to follow the guideline which says ask the patient if they have hematuria. This is not the way to diagnose bladder cancer. We should be doing early morning specimens of urine, 3 urine specimens, once a year, looking for malignant cells. It's extremely simple and it saves an enormous amount of problems. It's only recently that young people have survived long enough to get bowel cancer, but you can see that the risk for bowel cancer goes up exponentially over the age of 30 years. And by the age of 40, it's up at the level as if you had one or both parents who have bowel cancer. Our concerns are that we've had 2 young people under the age of 25 years who have developed bowel cancer, and one of whom has died from that problem. So it may be that we need to do better screening. Currently, all that's being done in our institutions is to ask for fecal occult blood, but teenagers and young adults do not like doing fecal occult blood, so maybe we should be doing colonoscopies more in this group. Looking at bone health in survivors of childhood bone marrow transplant again shows that osteopenia, osteoporosis, and particularly vitamin D insufficiency and deficiency are rife in these groups. So this is another area, very simple to deal with, but extremely important. Now, I know that gonadal function is probably the largest area, but I'm going to talk about this tomorrow, so I'm just going to give you a couple of important points here. We know that when the head has been irradiated, this disinhibits the hypothalamus and puberty tends to be early, and much to the confusion of families and sometimes of physicians, ongoing damage to that area causes loss of gonadotrophin, so that over about 10 years after cranial radiation, there is gonadotrophin loss and hypogonadotrophic hypogonadism. So this is an evolving problem that needs to be followed really carefully, from too much puberty to just right to not enough. And hormone replacement treatment is required. I thought I had 30 minutes, but they only gave me 20, so I'm going to continue. Primary hypogonadism occurs due to damage to the gonads by radiation, and so we want to know what works and what we should advise. What we should advise is that we don't tell the patient that they're perfectly okay under the age of 9 or 10. Normal gonadotrophins, even stimulated gonadotrophins, do not tell you anything definite about gonadal function until the patient's at least 10 years of age. So you can tell them they're okay and they're not okay at all. So be careful. The important thing is, what choices should we make? After cranial radiation, the cerebral vasculature is damaged. You will remember the nasty picture. Cerebral arteritis is recognised. There are early risks for cerebrovascular accident, as I pointed out, and you are in a position to be replacing hormones for these people. So this is the one time where you should do your very best to try and ensure the patient gets the lowest risk treatment possible. And that theoretically would be transdermal estrogen, because it bypasses the liver and decreases the risk, the procoagulopathic risk. However, in India, it's difficult to find transdermal estrogen. It's more expensive. The patches tend to fall off because of heat. And so another alternative is to use oral estrogen together with aspirin. And that's a perfectly reasonable alternative. The radiation oncologists are comfortable with that. So we're going to continue next session tomorrow with fertility preservation and options after childhood cancer, both male and female, and other forms of primary hypogonadism. So please come along, don't go shopping. I think that we must have long-term effects clinics, and they're beginning to be set up in many places. They identify the disorders as they come. They identify treatment dilemmas, whether we should treat or whether we should not treat, and specifically they identify changing circumstances. The combination of growth hormone deficiency and precocious puberty which, unless you have adequate data, you'll never pick it up. And it's no good patient coming to you 145 centimetres at the age of 16 saying, "Make me grow, doctor." You can't. Precocious puberty evolving to gonadotrophin deficiency, untreated gonadal failure presenting with a vertebral fracture for the first time, or a broken marriage, or infertility. This is not the way to go. You don't want evolving ACTH deficiency to present with an adrenal crisis as your diagnostic possibility, nor do you want a thyroid nodule to present as metastatic thyroid disease. You have to be careful of these young people because they can get ovarian recovery after cancer treatment. And of course, you want to deal with their bone mass accrual. So we want to assess evolving disorders, have psychological care, screening, and data and collection. Remember that these young people have risks for their growth, risks for their health, risks for staying alive. They have lots of social and emotional issues of memory processing, self-esteem and depression, and surprisingly, they have a lot of adverse behaviours. So please, everybody, take care of your patients. Thank you.